So Sunil is going to go over some of the medications that we give that are really specific to some of our spinal cord traumatic brain injury kids. So he's our expert in that. So go ahead.
All right. So today we'll kind of go over some of the common medications that we use. I'm going to try and expand more on particular ones, but there's more on some of the lists. But some of them that we more commonly use, I'm going to go into more details with those. I'm going to go into details about side effects, administration stuff, and all the nursing notes and goals that are associated with those medications. All right. So with regards to all the spasticity medications that we use, they're kind of broken down based on where the spasticity or how the spasticity comes about. Is it like generalized in the patients, like got spasticity across the board? Then we use medications like baclofen, diazepam. Those two are kind of like the mainstays. But then there's other choices. So there's dantrolene and then the tizanidine as well. If you only had focal, like you'll see some patients who only have one particular muscle group that's kind of like more spastic than the rest of the body. And for those patients, you can do focal kind of treatment. So we do Botox. And you'll see it's usually set up either at the bedside or at the day hospital. And then Dr. Korn will kind of inject the Botox depending on where he finds the exact location. He has to find the nerve and do all these checks and stuff. And then he'll inject the medication there. And then there's the regional one, so if you had like more spinal and so on. So that's where the baclofen pumps and so on come. But with regards to oral baclofen, that's the most common one that we'll see in our patients. Its mechanism of action is a GABA receptor agonist. So you kind of release the overstimulation of the muscle. The dosing goes all over the board since our patients are from babies all the way to teenagers and so on. Typically, baclofen for this use, for spastic use, is usually 3 times a day kind of dosing. So if you see once a day or twice a day, question it on why is it such off regimen kind of dosing. As we've all kind of seen patients on it, it's hard to, once you start, usually start on the low end of the dosing regimen for that patient, and then they'll work their way up to like effect. A lot of times the problem with it is even by the time you get to some effect, it kind of snows the patient or causes sedation. So you'll see that's one of the most common. So as you go higher on the dose, then you'll see more sedation since it's dose related. It causes overall across the day kind of like fatigue, weakness. Sometimes because it even relaxes your blood vessels, you'll see some hypotension with it as well. And then of course the incontinence. So those are some of the side effects to expect, and you'd have to monitor it as a nurse. So baclofen is tricky. It doesn't work with the first dose. You have to kind of accumulate it. It has to kind of spread through the whole CNS system and then kind of take effect with regards to generalized spasms. So it takes about 3 to 4 days for it to even start working. So generally, if you see a dose started, you'll notice that they're not titrating up. They're titrating up every 3 to 5 days and so on. But usually they'll wait for the max effect. Depends. Our patients are usually all like the trauma kind of patients. So those patients are hypermetabolic, so they might see effect quicker because they're blowing through drug and it's working a little bit quicker. So within 5 days, kind of leaning towards the 5 to 10 day range, you should start seeing this style of work. But then there's some patients who might be in slower metabolizers and are kind of taking forever to build up and so on. So those might be on the 10-day kind of end. And then doses will have to be titrated every few days, and based on the age and based on effect, basically. There's one important thing you have to realize about baclofen: you cannot just abruptly discontinue it. They'll go through baclofen withdrawal, and there's all these CNS implications and so on. So if it's not working in someone, or they're maxed it out and they find a better option to use, they have to wean it off. So you'll see a lot of times we have, like right now we have a patient on a baclofen pump that failed. As soon as they came in, it's going to take a while for them to replace that baclofen pump. We have to start them on oral doses. And then as the baclofen pump doses are being titrated up, the oral doses are being titrated down. So it's not like an on-off switch. Even when you're on both, you kind of transition from one to the other. So it's kind of like a gentle up and a gentle down. With regards to the IM form of both, would be Botox for like focal kind of spasticity. The mechanism of action basically is to block the muscle neuronal firing. So if it's overstimulated, you're basically blocking the stimulation, so there's no firing of that muscle. So that way you relax the muscle. So it's more of a neuronal kind of approach of how to treat that spasticity. So the dose depends on the muscle size, and a lot of other things like how many neuronal points need to be, how many need to be relaxed or blocked and so on. But usually they do all those kind of markings based on, Dr. Kornberg has a machine that measures it all and all that. So he'll come up with a dose set, and then he might have to do a couple of injections depending on seeing how many muscle points are basically getting overstimulated. That's the EMG machine basically. And then it lasts about 3 months, so every 3 months you might have to like redose. So that's basically the dosing component of Botox. Side effect wise, it works regionally, but unfortunately you still see some systemic side effects, so you might still see constipation because it's slowing down basically peristalsis in your gut. You might see some fever. Again, remember this is foreign material your body is recognizing, so you might see some fevers and so on. You might see muscle pain, especially at the injection site, and weakness. And then once in a blue moon, typically it doesn't affect your diaphragm or any of that, but you can see some respiratory compromise from it. But it's really, really rare. And then again, some of the other rare but serious side effects would be you actually, because it's derived from the botulinum toxin, so you could see some botulism from it, and they'd have to bring the IVIG to treat it and so on. But it's such a minimal exposure that it shouldn't cause it, but it's kind of like a theoretical side effect that can happen. And then abdominal distension and pain again from the constipation and then the muscle kind of lack of movement. All right, some of the clinical cause, especially when they come back to the floor after the injections, there's always going to be pain at the injection sites in the muscles. So you'd have to kind of like basically have the leg abductors, the calf muscle and upper limb flexors and so on. So basically you have to massage and relax the muscles. It's vital to keep those muscles moving. That way the drug does its job and it doesn't sit in one spot, and it keeps that muscle tone kind of like aligned still. It might take a few days for it to start working and seeing some effect, a few weeks, but usually it lasts up to about 3 months, in some cases up to 8 months. But usually in kids it's about a 3 to 6 month kind of range. Unfortunately, since it's kind of like derived from botulism, your body will kind of start seeing it as foreign and start developing antibodies to it, so then its effect can kind of go away with time. So you have to kind of be aware that this medication worked in the beginning, but then it stopped working, most probably because you're forming antibodies towards the drug itself. And at that point, they'll kind of redose or decide whether they're going to continue using it. For TBI agents, these are all kind of like medications that we use all the time. But my plan today was to just focus on some of the CNS stimulant medications that we've been using lately. Those are basically medications to keep the patient more coherent, awake, alert, and be able to participate in the rehab. So a lot of those patients, you'll see them on bromocriptine, you'll see them on amphetamines, and then sometimes rarely, but we do bring in the amitriptyline as well. On the flip side, we have some patients who actually overstimulated. There are trauma patients from the ICU and so on, that their sleep regulation is kind of out of whack, and they're not going through a normal sleep cycle, and then they're rehab ready in the morning. So they need more of a day-night kind of alignment and a sleep regulation kind of like fix. So those patients who've been using a lot of trazodone, sometimes we also use melatonin, and then now in the last year or so we've started using a lot of remeltion. So we'll talk more about that, but that's one of the other drugs that you'll see commonly being used recently. So with regards to bromocriptine, all of these basically the whole plan is to reduce the overstimulation and to kind of basically make your brain be stimulated just enough when you're waking up and not like overstimulated tired basically. So they all work around the dopamine receptor agonists. So basically it'll make you more awake and alert. And then you also have more control over, more motor control. So muscle coordination is more like kind of coherent. The usual dosing is there, I've kind of put forth, so depending on the day and the age, they basically have that dosing, and it's typically given twice a day. Some patients might need even doses. I've seen up to 30 a day, but this is kind of like the usual dose. So if there is a one oddball patient with a higher dose because they're metabolizing or they're just not having the alertness kicking in with at that lower dose, so they need a little bit more. The usual side effects for these are dizziness, fatigue, headache, constipation, and then you'll see nausea, vomiting is pretty high up there as well. So if you see any feeding intolerance and so on, it might be from the bromocriptine. For nursing pearls, we try and administer this around food. When it's given on an empty stomach, it can cause a little bit more GI side effects. So if you want to reduce it, they usually say fatty or even a regular meal should reduce some of the GI side effects. The other thing is, you should administer it, since it's twice a day. Don't give it at noon. You should try and give it as soon as the child wakes up, because it takes a little bit for those dopamine receptors to be kind of like activated and so on. You should give it within, as soon as the child wakes up. That way, by the time you start rehab at 9 or 10, they're more alert and awake by then. With amphetamines, they increase norepinephrine and dopamine. So again, the same way, it's focus, it settles down your mind, and you have a little bit more of a focus so that you can follow rehab instructions, basically. Depends on the brand and the formulation. If you ever see the ER, XR, CR, all those are once a day, versus like plain Ritalin is twice a day. But it's tricky. When we say twice a day, it doesn't mean morning, evening. Typically, plain Ritalin is given at 8 and noon. That way you don't have more focus when the patient's going to sleep that causes some insomnia and irritability and so on. In EPIC, it's tricky. If you try to do twice a day, you can't do BID. So just make sure for all the Ritalins and so on, under the frequency you have to type user, and it'll come up a user-specific frequency. So there, the whole table comes up with the days of the week and what times you give it. So you do Monday through Sunday, and you do 8 a.m. and 12 noon. And that's how you should order it, to kind of make sure it matches your MAR and your work list, and it's given appropriately. Side effects of it, headaches, insomnia, irritability. So that's why, because of these side effects, you don't give it at bedtime, and then the patient's sleep regulations are affected. But the whole goal basically is to make them more alert, follow instructions, and be able to do rehab and participate in rehab more actively. So we've kind of talked about this. The immediate formulations are BID, so again it's at 8 and noon. And if you see any of the extended release, those are once a day. So try not giving those too late. So try and give them by 8 if you can. That way they don't have hangover. If you give it at noon, then they won't be going to sleep till like 10 at night or 11 at night, because they're still kind of like more awake from the late morning dose. All right. Amitriptyline, again, it increases the CNS concentration of serotonin and norepinephrine, so it'll make you more stimulated, awake, and be able to follow commands. Its dosing is there, and usually this is the usual dosing, but you might need bigger doses for some patients. Some of the side effects from this that we see is hypotension, palpitations, syncope, tachycardia, constipation, nausea, and vomiting. So again, if you see any of those kind of side effects, it might be drug related. For clinical pearls, again, we try and give it to patients, since you can give it twice a day. Give the second dose by 8 at the latest. If you give it at 10, 12 at midnight, then the patient might be a little bit more awake for too long. Remember, it makes you more alert, so you don't want to give that too late at bedtime. Unfortunately, this medication is given 1 or sometimes twice a day, so that second dose, try and give it early. So 6 o'clock, 8 o'clock is the ideal when we want to give it. All right, trazodone. This one is unique in the sense it helps with your sleep regulation, but originally it was helped with some of the depression and those kind of uses. So this is kind of like a 2-for-1. So if you had a patient who was like a classic patient, or was a teenager who's not happy with, I don't know, dad burns or trauma or something, and they go through that teen brain and they're kind of more on the downside with regards to happiness, and then their nights and days are messed up because of PICU intubation, the whole day and night kind of confusion. This is more like ideal drug for that kind of patient. So you'll help them with depression as well as regulating their sleep cycle. This one is pre-sedating, so you have to give it at bedtime. The dosing ranges anywhere between a quarter tablet, half tablet, and so on. It comes as a 50 milligram and 100 milligram tablet. So that's how we count with the dosing. It doesn't have a liquid and so on. You won't find too much pediatric dosing for rehab sleep regulation, but we're using the lower depression kind of doses to achieve the same goal. Unfortunately, it causes a lot of sedation, dizziness, headaches, fatigue, nausea, vomiting. So as you've realized with these side effects, all of these hit the CNS system. So usually any medications that hit the CNS system, you'll notice these are the similar kind of side effects across the board. But this one's pre-sedating, so you have to be careful. You want to give it pre-early, so if 8 o'clock's bedtime, give it at least 30 minutes before it kicks in. It takes about 30 minutes to work. But you don't want to give it late at like midnight, because then they'll have a hangover the next morning, they won't be awake and they'll still be sleepy by like 10 o'clock. So try and give it as ordered by 8 o'clock. Unfortunately, you might see someone thinking once I've seen 1 or 2 orders, not on us, but on the adult side, where they ordered once a day and then they put it at 8 in the morning. But that's not ideal, because then they'll be sleeping during the day and awake all night, and it defeats the purpose. So if you see an accidental order placed like that, just make sure it's QHS for 8 o'clock. Again, this has to be given scheduled. It's not a PRN Benadryl to help with sleep. It has to be scheduled to kind of regulate your sleep day and night cycle. It's not a one-time dose and then it fixes your day and night, it's more of a transition. So all of these patients who've had their day and nights kind of out of whack, it takes a few days, a few weeks to kind of regulate that. But then we usually continue this or wean down just to help with the depression or the mood stimulation. So to achieve that goal, kind of we can continue this. It does cause a lot of dizziness because of its sedating properties, so just be careful that the patient is not waking up in the middle of the night to go to the bathroom without any help, because there's a chance for falling and so on. So if a patient looks pretty sedated, just make sure you have any necessary precautions you need. Dosing after meals will decrease the lightheadedness and postural hypotension. So they say give it after your dinner, like an hour or 2 after dinner to kind of help with that. Ramelteon is basically a melatonin receptor agonist, and it kind of replicates the generic melatonin, but this is the brand name version of it. It comes as an 8 milligram tablet, and again, there's not a pediatric dosing system for this, so we go with quarter tablet, which should be 2 milligrams half, would be 4, 3/4, and 8. Depending on the patient and how bad their day nights kind of out of whack, we'll start with lower doses and we'll say we are. I think this year we've at least had like 7 or 8 patients we've sent out of the PICU on this. And we've had pretty good success with trying to regulate this season. But the key is again to make sure it's given scheduled and not PRN. This is not Benadryl. It doesn't regulate your cycle after one dose. You need repeated multiple days, and that way you're taking that kind of regulation. Unfortunately, it still has that hangover effect, so you can get some dizziness and somnolence, and fatigue with it. But on the flip side, some people actually get like a paradoxical, and actually they'll worsen the insomnia. So those patients, you can stop this medication because the purpose you're using it for is actually worse. But again, most of the patients we've used it on, they haven't had the insomnia issue. They've had more of the somnolence kind of issue. And then again, since it's affecting your CNS, you might see some nausea, vomiting with it. So with this medication, again, give it 30 minutes before bedtime. It does take a little bit to start having some effect. And it has to be given scheduled, not PRN. And then make sure if you need have a patient who's kind of on the fence with regards to risk for falling, and you take all precautions around the patient, the bed, and so on, bed alarms and so on. That way you know that they're safe after taking this medication. So in summary, since all the medications we've been using kind of all revolve around the nursing hands on how they're giving it and checking and so on, we kind of have to make sure we don't miss any doses. And then we try and give it in a timely manner if it's possible. I know sometimes you have many patients and many other needs, but if possible for these medications, if they're given on time and not too late and so on, then it'll work better for the rehab kind of aspect of the patient. If you've had Botox and so on, you'd have to make sure the muscles keep on moving. The injection sites are monitored. And then again, if there are any side effects that we've kind of talked about, if you see, if it's mild, you might want to keep on monitoring, but if it's moderate or severe side effect, bring it up to the rehab team's attention. That way they can kind of decide what to do with this medication. And with that, I'm open for any questions. Yes.
Do we carry melatonin?
No, so we don't carry melatonin. This is the problem with melatonin is it's not FDA regulated, so we can't even buy it. We'd have to go through FDA. But this is the FDA's version of brand name melatonin. It works very similar. But
The ones I call natural, this one's not.
yeah, it's not natural. But again, for those patients who prefer to just use pure melatonin, they can bring in their own supply and use it.
Does this have an addiction thing to it?
I haven't seen it. The few patients we've used it in, I haven't seen. It purely hits just the melatonin receptors like melatonin itself, and so it should be kind of like, yeah, or comparable.
Cool.
Thank you.
Thanks.
Thank you.